My today's topic is heat-related illnesses. As we are facing the extreme heat in Ahmedabad, this topic might be useful. We may not face the extreme sick patient, but the moderate cases we do get in the emergency room. So this might be useful because patient presents with a different manifestation, which are not they present with any GI complaint or any complaint. So it will be useful if we can diagnose that from the symptomatology. So introduction, heat-related illnesses are spectrum of diseases ranging from the heat rashes, heat syncope, heat cramps, heat exhaustion, and fatal medical emergencies like heat stroke. The thermoregulation in the body is maintained by the preoptic nucleus in the anterior hypothalamus. It maintains the all heat dissipation pathways and maintains the body temperature within a normal narrow range. There are four pathways by which it maintains the body temperature. One is the evaporation evaporation of heat from skin in form of sweat, but it becomes ineffective when the humidity is more than 70%. Second is the radiation of infrared electromagnetic energy into surrounding. This is mainly useful to heat gain and not the heat loss. Third is the conduction, which is a direct transfer to the cooler object, like when we apply the ice packs. This method works. Convection method, loss of heat to the air current. It also becomes ineffective when the environmental temperature is more than the skin temperature. When the body temperature rises above 104 degree, which happens in the heat exhaustion and heat stroke, there is an increased oxygen consumption in the body and the basal metabolic rate increases, which leads to tachycardia and tachypnea, which leads to oxidation-induced systemic inflammatory response. And there is a release of heat shock protein. And there is because of that, there is a shunting of blood from splanchnic circulation to skin and muscles, leading to GI ischemia and release of endotoxin. And these endotoxin eventually leads to multi-organ dysfunction. Hepatocytes, vascular endothelium, and neural tissue, they are more sensitive to this heat shock protein. So they are first affected. Thereafter, all organs are eventually affected and ultimately leading to DIC. What are the predisposing factors for heat-related illnesses, especially severe heat illnesses? Are the extremes of age, old age and children, pregnancy, obesity, poor physical condition, like those who are not physically fit, lack of acclimatization, dehydration, heavy alcohol or other illicit drug overdose, cardiac patients, those who are on diuretic, beta blockers, or some psychiatric patient who are on anticholinergic medication, anti-epileptics like topiramate and salicylates. So now we talk about the disorder. There are some minor heat-related emergency syndrome. They are heat edema, which is in form of mild swelling in the hands and feet and ankle. It is because of excessive heat, the antidiuretic hormone level increases. Also, there is a peripheral pooling of blood and cutaneous vasodilatation, which leads to edema. But it can be easily distinguished from the systemic causes of edema by the history and physical examination. Heat rashes, they are just a prickly heat type of maculopapular rashes and pruritic in nature. They mainly occur in the neck, upper chest and groin region and under the breast. The treatment is antihistaminics and mildly salicylic based preparation in form of talcum powder or dusting powder or any lotion. The heat syncope, it occurs in the people who exercises a lot, or who are dehydrated because of medication or for some other reason, and sudden getting up from the sleeping position. It can follow endurance exercise and can occur in elderly. The mechanism is postural hypotension because of decreased venous return. Hyperventilation tetany, because of high temperature, there is a hyperventilation which leads to respiratory alkalosis and which leads to carpopedal spasm, classical of tetany. But these spasm are not very painful, and only the rehydration and supplementation of the solutes will resolve the problem. So reassurance is the treatment and main rehydration. Heat cramps. They are painful intermittent cramps, especially occurs after strenuous exercise in extremely hot weather. And sometimes these people, they do hydrate themselves with plain water, but they forget to take the salt intake. And due to deficiency of the solutes, the cramps occurs. So advisable is to take the isotonic water and not just the plain water while doing vigorous exercises. And this is also treated with the electrolyte solution, the commercially available preparations. Heat exhaustion. It is a stage prior to heat stroke. The hallmark of heat exhaustion is the central thermoregulation is maintained and neurological symptoms are minimal or absent. The main symptoms of heat exhaustion are temperature, but which is less than 105 degree Fahrenheit, diaphoresis, extreme weakness and lethargy, skin is moist and clammy, nausea, abdominal symptoms, dizziness and confusion. Muscle cramps can also occur, and there is a rapid shallow breathing. Heat exhaustion, treatment of heat exhaustion is remove the object from the heat source first, and cooling, aggressive cooling measures that we will discuss later, water and salt repletion. It may recovers with the primary treatment within few hours, but sometimes it may progress to heat stroke even after the initiating treatment measures. Now we talk about the heat stroke. The heat stroke core body temperature goes more than 105 degree, which is associated with the dysregulation of the thermoregulatory mechanism, and there is a neurological involvement. There are two types of heat stroke, classical and exertional. Classical heat stroke occurs because of the purely in elderly people who are already having systemic illnesses on medication and due to exposure to the environmental heat, while it occurs in the elderly people, while the exertional occurs in the otherwise healthy young individuals. Symptoms are the fever, temperature more than 105 degree. If the patient initially coherent, then they will complain of weakness, lethargy, dizziness, altered sensorium, agitation, irritation, slurred speech, eventually go to ataxia, delirium, seizure, and coma. The signs are, the patients are generally high temperature, tachycardia, tachypnea, many tachyarrhythmias can be present on presentation. On examination, there are bilateral crackles on the chest examination, which is a non-cardiogenic pulmonary edema, petechiae or ecchymosis in the skin, wide pulse pressure and hypotension. The mainly encountered complications of heat strokes are ARDS, DIC, acute kidney injury, hepatic injury, hypoglycemia, rhabdomyolysis, seizure and coma. See, in classical heat stroke, neurological symptoms are more common in elderly people, while the exertional heat stroke, cardiac symptoms and electrolyte based symptoms like hypoglycemia, rhabdomyolysis, hyperkalemia, hyponatremia are common. The mortality is high, ranging from 21 to 63%, depending on presentation of the patient. Like when they present with the seizure or oliguria or very high temperature, the treatment has been delayed, then the mortality is high. Diagnosis of the heat stroke, mostly based on the clinical scenario, the triad of exposure to heat, and there is a temperature more than 105 degree and the patient is neurologically disturbed. It is a clinical scenario, but we should exclude the other causes of hyperthermia like infection, exertional hyperthermia, endocrine causes like thyrotoxicosis, CNS causes like hypothalamic infarct or meningitis, oncological etiologies, and toxic drugs. The close differential diagnosis which may come across is the neuroleptic malignant syndrome and malignant hyperthermia. What are the investigation? The diagnosis is mainly clinical, but the investigations are to find out the involvement of the other organs. Chest X-ray to rule out, to look for the pulmonary edema. ECG to find out dysarrhythmia, conduction abnormality, myocardial infarction, myocardial ischemia. The laboratory tests are the renal function test, liver function test, ABG will show metabolic acidosis with respiratory alkalosis. Leukocytosis up to 30 to 40,000 WBC count because of hemoconcentration we can see. Urine myoglobulin examination, but just checking the urine color, brown color urine itself will say for the speak for the rhabdomyolysis. And CPK MB for the cardiac damage. And toxicological screening. Toxicology, when the patient does not respond to the cooling measures, like neurological improvement does not occur with the initial cooling measures, then the toxicological screening should be done immediately. And CT brain and CSF analysis. So management of heat stroke is rapid cooling, which is foremost important, correction of the electrolytes and supportive care. Cooling. First of all, remove the object from the source. Rapid cooling by the AC fan. You can do the cooling by any measures available, sponging, cold bath, even the exertion. But the cold bath should be avoided in the elderly people. It should be used in the young adults. Body cooling units are available. There are commercial cooling blankets, cold oxygen, cold nasal device. They are available, but they are not much useful. Small dose of sedative is useful to avoid the agitation and seizure. Stop the cooling when the continuous cooling rectal temperature should be checked, and it should be stopped once the temperature is 102 degree. Airway and breathing, because most of the patient have undergone aspiration, so mechanical intubation should be done, and ventilation, airway, breathing should be secured in a standard way. There is not much water deficiency actually, but initial replenishment of the with the isotonic saline 250 to 500 ml bolus, CVP will be high in spite of hypovolemia. So the measures are the pulse rate, BP, and urine output, and accordingly we should do the fluid resuscitation. We should avoid the alpha agonist because they causes the vasoconstriction. If required in refractory cases, we can use dopamine or dobutamine. Pharmacotherapy is generally not required in the heat stroke. Acetaminophen, aspirin have no role. In fact, it worsens the hepatic injury and DIC. Dantrolene is ineffective. IV antibiotic may be given till we develop the infection. And we can send the blood culture. So actually heat stroke treatment is always a supportive treatment and cooling measures, but the prevention is better. So avoid exposure to heat for prolonged period. Wear porous, light, loose clothing. Drink isotonic liquid and water adequately, and avoid vigorous exercise in hot and humid condition. Thank you.